This is the last coverage for your exam 4. Let's begin with hearing loss. There are 3 types of hearing loss. Well, of course, the signs and symptoms will be the same. The patient will be able to hear. These are the risk factors. It really depends on the type of hearing loss. So let's get right to it. You can read, so just read these and then you can easily relate that to the types. Hearing loss can be conductive, sensorineural, or mixed, meaning both types in one. Conductive hearing loss is more external, involving not only the external part but all the way almost to the inner ear. However, the sensorineural hearing loss is more damage to the auditory nerve. If I look at the causes which are here in table 48.1, if I put all these together, here we have 4 examples of conductive hearing loss. These more involve an obstruction type, meaning this one obviously are obstruction, but so is otitis media, because in otitis media there is an infection that will cause swelling and inflammation. So in a way it will also cause mechanical obstruction into the ear canal. Same thing with ear trauma, because that will cause inflammation and swelling, and tumors will physically cause an obstruction. Sensory neural, these groups here, sensory and neural loss, are more inner damage, damage already to the auditory nerve, that like I mentioned earlier. It will include autoimmune disorders such as MS. This will be discussed next semester. Here are some drugs still causing sensorineural. However, we can easily, well, not, I shouldn't say easily, because sometimes there's no other antibiotic that will work. But if the doctor has a choice, meaning there are other alternatives, then we'll try to avoid these medications if they are causing damage to the patient's hearing. But sometimes they can't, there's no other alternative, so they weigh the benefits versus the risk. So for instance, if we're obviously trying to save the patient's life from sepsis, then the hearing loss here would be a calculated, unfortunate side effect. Manifestations. Obviously the patient can't hear, but it goes beyond that. As you can see here, the patient's behaviors will lead to social interaction, social relationship strains. I see it a lot on my in-laws. They have these frequent fights just because the other cannot hear. Actually, both of them can't hear, so they end up fighting all the time. Medical management, the treatment really depends on the cause, whether it's conductive, sensory, or sensorineural in nature. Diagnostic tests, I really have no questions on these. The ones that nurses take part of, especially in the school setting, is this one. We conduct audiological tests all the time. It's just a small machine, and we attach noise cancelling headphones on them, and then the machine delivers different frequencies, and then the child simply lets you know whether or not they can hear it. treatment, like I said, will be depend on the cause. So for instance, it's caused by a tumor, then the treatment will involve removal of the tumor. Or if it's from, say, MS, then that would involve corticosteroid. Noise exposure, I mean, what can we do with that? That will be for the types, like for presbycusis, which is age-related hearing loss. This is progressive hearing loss related to age, and noise exposure. These are permanent now. So of course the treatment for that will be hearing aids. Alright, so here are hearing aids. We have different types. The smaller, the more expensive the hearing aid. There's also surgical procedure, Tympanoplasty. Again, this is a surgical procedure, so our tests will involve pre and post-op care of the patient. Cochlear implants are more popular among the younger population, usually those with congenital defects. Usually if the patient has some mental retardation or other congenital disorders, they will have hearing problems. So for those children, they'll have cochlear implants. We actually have a figure here. This is an example of a cochlear implant. So here is your implant right here, surgically implanted into the skull, and it's connected to a external transmitter. And here is the electrode going into the inner ear. Of course, it's a foreign object, so people who receive cochlear implants definitely are at risk for infection. In fact, they are candidates for flu and even pneumonia vaccines before the age of 64. So between 4 years old to 64, they will need to always avoid crowds, stay away from people with respiratory infections specifically, and again prevent respiratory illnesses by taking the flu and the pneumonia vaccine, obviously for reasons that because our ear and our oral or upper respiratory tract are connected. So if you get an upper respiratory infection, then usually it goes to your ears. For those who have kids, you know what I'm talking about. Here we did that. Here again are the explanations for this clinical manifestations. Okay, since we have the surgical procedure here, Tympanoplasty, here is a specific post-op positioning and rationale. And again, I already mentioned avoiding people specifically with upper respiratory infections, and here increasing fluid intake, because cerumen is under conductive hearing loss. And some teaching here, obviously we don't use cotton swabs, okay, to remove earwax. There are safer ways to do it, although we teach this, but we practice that all the time, including myself. I still use Q-tips to clean my ears. Prevention would be noise protection, especially if your livelihood is, let's say you're in construction, you're a contractor using jackhammers, for instance, or if you're at the airport, you work with planes. What else? You are a equipment manager for concerts, for instance. Those hazardous livelihoods, or even just lawn mowing. Okay, so you're exposed constantly to loud noises, so it's good to wear hearing protection. And that's about it for hearing loss. Let's proceed with, we don't do external otitis or otitis media, so we'll skip that. We will go to the next page. Although we don't do otitis media, we do have the eardrop administration here. So we discuss application of administration of eye drops. Now, so here is eardrops. Again, please go over the procedure. I won't read it for you. Be careful with preparation, infection control, warming of the bottle, proper positioning of the patient before administration, and how you pull the ear, the pinna, the outer ear. So this is an adult, obviously, because we are pulling it up and back. For the child, it will be down and back, and including this, because they need to do that so that you spread the medication into the inner ear. And that's about it. So let's go now to not testing those, and we already did a few on surgery. Okay, here's a little bit more on post-op care. There should be no, because we can't get the ear wet, plus there will be an earplug, which is usually a cotton ball that they put in the ear after surgery. The patient must not get the ear wet, so that would include no showers, because if you take a shower, of course that will get your ears wet, and definitely no swimming in the pool. Baths may be okay, laying in the bathtub with your head above the water, that's okay, but definitely no showers. And this one you should already know. This is a general teaching on antibiotics, and that's it. Tinnitus will skip, that's not in our module. Let's go next to vertigo, I believe. Yes, vertigo. Vertigo can be a disorder on its own, or it can be a manifestation of Meniere's disease, which is our last topic. So vertigo is your world spinning. Okay. So this is a transient feeling of spinning and dizziness. But for these patients, though, if it is a primary disease, then this would be very frequent. This can be debilitating. I mean, how can you go to work with this disorder? I mean, you can hardly stay up, right? These are some risk factors that can cause vertigo. Again, Meniere's disease is the next topic, which is one of the hallmark features of Meniere's is vertigo. Management for vertigo are medications that you take over the counter, like Bonamine, for instance, Dramamine, for motion sickness. Prescription medication, I think Meclizine is also over the counter. For severe cases, Meclizine won't be enough, so the patient will also be taking Valium. Okay, so if you're relaxed, or this is obviously a sedative, then no, if you're not awake, then you won't have vertigo. Okay, then we have chlorperazine, which is Compazine. This is actually for nausea. Of course, if you have vertigo, then that will cause nausea. So we have a cocktail of medications here. You've heard of scopolamine. This is a behind the ear patch, also for motion sickness. And we have Robinol, and we have non-pharmacologic interventions also for vertigo shortly under nursing care. These are the complications of vertigo. Like I already said, it's debilitating. You can actually be disabled if you suffer from frequent vertigo. Here, because you can't do these anymore. You can't drive. You can't go to work, right? So this is what I mean by you will be on disability, unfortunately. And here are the explanations for your signs and symptoms. Now, I mentioned non-pharmacologic interventions are here. So these on top of your medications, which we had several. These are non-pharmacologic. So one is take it easy, rest, change movements slowly. Okay, and then for your diet, this have been proven to decrease incidence of vertigo. Stress can exacerbate it, so here are some stress reduction techniques, and here are some herbal medications known to treat vertigo. We already mentioned changing positions slowly, and it was also help. Like if you dim the lights, for instance, less stimulation, which will be under reducing stress, I guess. Decreasing stimulation or decreasing CNS excitability. And fall precautions, very important. Here's the fall precautions right here, and some of these are already mentioned under nursing care. And that's it. Last part is Meniere's. This is an inner ear disorder. This has 3 signs. One are right here. 3 clinical manifestations are hearing loss, tinnitus, and vertigo. Problem with this, just like vertigo, this is also debilitating. Most people with the disorder, especially if they can't get it under control, or when they're having attacks, this can be again debilitating. They are disabled because the symptoms last from several hours to several days. This is not a good way to live. Here are some causes and also risk factors, or you can also say these can also exacerbate or trigger an attack. There is no cure for this thing. You can only manage it. Here is the pathophysiology. It's kind of like the same mechanism as glaucoma, wherein you have increased intraocular pressure in glaucoma. This one is increased intra-auricular pressure. Okay, so this is from an excess of endolymphatic fluid. You have buildup of pressure inside the ear, and which causes obstruction of your inner ear canal system. Manifestations, obviously, we have 3 again. There's hearing loss, tinnitus, and vertigo. And vertigo will always be accompanied by nausea, vomiting. With sudden movements that will exacerbate the symptoms. Okay, and you also have uncontrollable eye movements. The medical term for that is nystagmus. Nystagmus. Diagnosis is made by several. One is balance testing, and of course based on the patient's clinical symptoms. Their report about how often these things happen, what are the and if they have the three hallmark signs, then we make a clinical diagnosis of Meniere's. Again, these are the some of these were already mentioned under Vertigo, so the management is similar. So we already said from under Vertigo, avoid sudden movements, low salt. There were a few low glutamate and aspartame in the diet. No, it was avoid aspartame. Get plenty of rest, acupuncture, limit alcohol. It doesn't say smoking, but I don't think it will hurt if you stop smoking, because that was mentioned under Vertigo. For severe cases, they will consider labyrinthectomy. Okay, this will help relieve the symptoms, or at least decrease the frequency of the symptoms. Again, this is ear surgery, so pre and post-op care is the same because it's the same ear they're doing surgery on. So same thing, there will be a earplug, so you can't get your head wet. Therefore, only take baths, no showers. Don't use Q-tips to put into your ear. I forgot to mention, if there are activities that increase intraocular pressure, which are the same activities that will increase intracranial pressure, since the ears are in the same head. So those activities will also be should also be avoided here in ear disorders, especially post-op, because you don't want to increase pressure in there. Here are rationales for which I already mentioned earlier. Rationales for why the patient is on these drugs. Okay, and that's on your blueprint. Here are rationales for your intervention. Signs and symptoms, and that's it. Again, nursing care is similar. Here's limiting salt intake again, proper positioning, fall precautions. Yeah, that was very short. It's not supposed to be long.